Hello and welcome to another episode of Conversations with Chanda. We hope you all are doing well, given the circumstances. Like many of you, our team is working remotely at the moment and continuing to bring fresh episodes through virtual conferencing. We hope you enjoy this episode and stay safe, practicing social distancing together.
Thank you so much for agreeing to have this conversation with me today. If we could just jump in and, if you could each, maybe Natalie, we'll start with you, just providing an introduction to who you are and how you got involved in health, and just whatever you want to share to just get our listeners to know who you are.
Okay, great. So I'm Natalie Davis. I live in Washington, D.C. with my husband and 4 kids who are all being schooled downstairs, so you may hear them. I studied throughout my bachelor's degree and master's degree, really studied sociology and how one's social environment impacts one's view of their self. And at a time, I was really interested in anorexia and bulimia. And then that's when food deserts were being discussed at a more national level, and came to Washington, D.C., where my husband was studying to be an immigration rights attorney and was trying to find a job. I had a headhunter look at my background and say, "Oh, you're interested in anorexia and bulimia, and that is healthcare." And I was like, "Oh, I've never thought about it as healthcare." And so I got a job and started doing the nonprofit circuit here in Washington, D.C., and had the opportunity to work for the Obama administration starting in 2010 when the Affordable Care Act passed, and thought I was going to be a smart policy person, and realized there are a lot of really smart policy people here in Washington. And what I loved was going out and talking to people and to providers and advocates and understanding how the policies of the Affordable Care Act and the Center for Medicare and Medicaid Services, how those actually live in real life, and how we can do better to serve people by making stronger policy and operationalizing that policy in a way that really was a way that people could take advantage of the good work that the federal government did and does. When healthcare.gov went down, the team that I was on, we had the opportunity to work with Andy Slavitt, who came and rescued, along with a lot of other people, rescued the website, and then he became the administrator for the Center for Medicare and Medicaid Services. I had the benefit to be his right hand and had so much fun going around the country with him and talking to people. We set up a listening tour and really, again, got to do what I love doing, which was going and talking to people and hearing about their lives and how healthcare and policy can make their lives better, which brought us to start United States of Care, the organization that I helped co-found, and now am the director for public engagement, where, again, I get to go out and talk to people about how they experience healthcare, and really am bringing that to not only make smarter healthcare policy, but really change the narrative on healthcare from something that is super politicized and thought of as something people can get political wins on, instead of the issue when you talk to real people or talk to people about healthcare. It's a personal issue. It's a family issue. It's a community issue. And so changing the narrative and making sure that we are talking about the right issues, talking about people's needs, and really bringing that into the policy-making process is where United States of Care and the organization that I am helping to lead is really focused.
And Dr. Lisa, what about you? What is your background? And if you could share a little bit about yourself with us.
Sure. Thank you. I appreciate the opportunity to be here. I'm looking forward to this conversation. I'm an infectious disease physician who trained in public health at the CDC. I was an epidemic intelligence service officer. A lot of people may not know about EIS officers. These are the medical detectives who investigate outbreaks. So I'm sure right about now, they are fanned out across the globe, quietly doing their work. And after my time at CDC, which was about 10 years, I moved to Washington, D.C., which is where I am now. And here I've had a variety of roles in the health sector, from academic, being an academic researcher, clinician, and I call myself a community health activist because I love to be out in the community, on the ground, listening to people, hearing what's going on. And I was also the chief medical officer at Washington, D.C.'s Medicaid program. And after all these experiences, was most drawn to understanding what's happening around healthcare with people and how they're understanding health and healthcare. And so I've ventured off into health literacy, and I've started my own company called Grapevine Health. And the company is called Grapevine Health because there is an unrecognized wisdom around health and healthcare in the community that's being communicated through people. The problem is sometimes the information is incorrect, and I believe people like me need to be inserted in these conversations to improve health literacy, but also to share health experiences so people don't feel so alone in their healthcare journey, because it can be very daunting and scary. So my company is really, we're really in the beginning stages, but this pandemic, I think, was tailor-made for someone like me with my background in public health and infectious diseases, but my interest in addressing health literacy, because there's been so much misinformation rampant on the internet, especially, but also in community about this virus and what it's doing to people. So I'm ramping up efforts around addressing misinformation related to coronavirus. And hopefully that will position me to move things forward, including my video series called Dr. Lisa on the Street, which has been a bit of a challenge right now. I'm still out in the community, some doing service, but it's not the same as Dr. Lisa on the Street, which is walking up to people and asking them to talk to me about a health issue. So I'm sure that will continue, but for now, we'll be focusing mostly on online health information and addressing misinformation as best we can on social media.
Mm-hmm. Thank you for that. Natalie, how long has United States of Care been operational?
Yeah, we're a new organization. We launched in 2018. So got a couple of years under our belt, but even with that, have a great track record that has really taken off, especially during COVID, but a great track record of working at the federal and state levels with politicians of all party, and are at the same time out talking to individuals and people about their needs and their experiences, and doing that from more of an ethnographic point of view, just like Lisa said, is going out and talking to people. We've had community conversations in San Diego and Dallas and Philly, and phone calls and Skypes and individual conversations across the country. And so really are, just in these 2 years, trying to meld these worlds of policymaking and understanding people's experiences in order to drive that kind of path of new way of thinking about policy.
Mm-hmm. I mean, in both of your cases, the work that you're doing has kind of evolved recently in the middle of hopefully something that we never see again in our lifetime. How is this moment evolving your work? Is it reinforcing what you already knew? Is it bringing surprises? Is it presenting new opportunities? Or
yes to all of that. We are finding when we talk to people that this is not a political issue. It shouldn't be a political issue. It shouldn't be about political wins. When you talk to people, it's about they are concerned on these unknown times. They're concerned about themselves and their families. And they are concerned about frontline healthcare workers, and they're concerned about going back to work. And so when we sent a letter to Congress 2 days ago with what they should be focused on, we centered our recommendations on what they should be working on and what people want and need. And so we really have ramped up our recommendations to state lawmakers. We've sent out state checklists for what they can be doing to get their state ready and their and in a better place where their citizens and others are safe. And we've been sending letters to Congress and working with the administration to really make sure that what's put forward is centered on what people need and not necessarily what the industry, what we think of as big lobbyists who would be lobbying for certain things. We're really there to amplify the needs and voices of people. And so to more straightforward answer your question, yes, we have seen so much more opportunity to put forward our point of view on this is not about political wins, it's about people's needs. And here's some smart policy that can meet those needs.
Mm-hmm. And Dr. Lisa, how's it evolved your work, and what are you noticing?
I'm noticing that the more things change, the more they stay the same. I think a lot of the narratives we're seeing in the media don't apply to some of the communities I'm working with and walking amongst. For example, the homeless population largely feel the messages, the prevention messages and public health messages don't apply to them. I interviewed a director of one of our homeless service agencies, and she said these messages telling people to stay home, keep your hands clean, and socially isolate are very difficult for someone who's homeless to implement. First of all, they don't have a home. And the places where they might find water throughout the day are now closed because we take for granted that businesses will be open. And when they're open, a lot of homeless folks rely on them being open to use bathrooms and obtain water and things like that. And then finally, this population is already socially isolated. And so now we're asking them to isolate even more. And so the concern is, and the things we're not talking about, are what will be some of the mental health impacts of what we're doing, this epidemic, and how it's going to affect long-term and even in the short term, how it's affecting vulnerable populations. So the reason I say the more things change, the more they stay the same, is because none of these disparities surprise those of us who've been working with these populations. And so I think as we evolve our conversations about how to address health disparities, we really have to be intentional in thinking about what the concrete solutions should be. I really hope that we won't simply have convenings and create task forces and create more reports, but that we will actually create some actionable change. So those are the things I'm thinking about right now.
Yeah. So I'm just going to ask questions. I know we're on this Zoom and hopefully we'll be able to just go for it. But there's a couple of things, especially Dr. Lisa, when you were talking about just the misinformation that's out there. Mm-hmm. And which existed before, right? And as soon as you said it, I could hear my grandmother in my head giving me her solutions to my ailments. I thought I had an ear infection a couple of weeks ago, and I'm like, oh, I just need a little sweet oil and a cotton, and some cotton. I'll pop it in my ear. I'll be just fine. And, we have those things that get passed on in community. And can you talk about, so you have both kind of the grapevine of health, right? Which is like misinformation or ways that we manage things in our communities that could be improved if we actually had a primary care doctor and went there. And then we have misinformation that's being put out in the public. Can you talk about, damage is a really strong word, but the damage of the misinformation that's out there and how and what that's done to in light of a situation that we're in now?
Yeah, the misinformation is harmful. And the reason I'm so passionate about addressing it is because I believe misinformation thrives because there aren't enough credible people speaking truth about these issues at the same time or trying to dispel the myths. And so if you don't have enough people dispelling the myths, the misinformation can take off like wildfire. And there's a saying, I think it was Mark Twain who said, bad news travels halfway around the world while the truth is still putting its pants on or putting its shoes on or something like that. I think this is very appropriate for what's happening with misinformation. One of the most harmful things, I believe, in early days of this pandemic, when it hit the United States, is that there was a joke going around that Black people were immune to coronavirus and we wouldn't be affected. And that joke actually turned into lore. So now we are looking at the effects of that. People still don't believe that this is an issue, not necessarily just for Black people, but that maybe it's not real at all. And I think by the media mostly displaying people of authority or people who are visible, like actors and athletes having the virus, people went to sleep. The other thing that's circulating a lot is about prevention and treatments and cures. And I think this is harmful because people believe that some of these things will protect them from coronavirus, and maybe they won't practice social distancing, or maybe they won't practice good hand and face hygiene. So an example of this is, and I still get questions about this information that floated early related to coronavirus hanging out in the throat. And if you drink hot water, it washes the virus in the stomach, and then you won't get COVID. And I had to explain, and I actually created a little video about this, showing people the difference between the airway and the esophagus or the food tube, and why, even though coronavirus might be hanging out in the back of the throat for a minute, that drinking hot water alone is not going to prevent you from getting COVID, because it's an airway, or it's related to breathing and the lungs. So I think I could go on and on about all the misinformation, but those are just two examples of how information gets on the grapevine, gets spread around, and then people are not positioned to take care of themselves.
Mm-hmm. And this is where we're so honored to have Lisa as an advisor to United States of Care. When I first met her, I remember, Lisa, you were talking to me about how misinformation and health literacy is one of the social determinants of health that no one really talks about. Mm-hmm. And it's something that could be way more important than understanding if people have access to food, or just as important, but yet we never talk about it as a social determinant of health. And so, like you said, we're kind of living through that right now, and something that a lot of people don't really recognize.
And I'm glad you bring that up, because even when I talk to people about the need to support health literacy efforts, or efforts to address misinformation, I think people don't see the value in addressing misinformation. They say things like, well, people can look on the internet. I mean, the internet is creating this problem. Or there's so much information out there. It can't just be providing information alone. It's not that providing information alone is the solution, but it's definitely a vital part of the problem that we have to address, because if people don't understand how to take care of themselves or how to understand the information, then they can't take action.
Mm-hmm. And, Natalie or Dr. Lisa, what happens when it's the government that is putting out misinformation, right? So there's DC, and then there's, governors that I've seen across the country, and their agents that seem to be putting out information and then backtracking later. Is there an answer to that?
I think that this is it's a tricky time, because the problem with the communication around this pandemic is that a lot of the communication is based on modeling. And people have to understand the limitations of modeling. Modeling is very good for something like the flu. We've known about the flu for decades. We know about how many people will be infected. We know about how long it's going to hang around. We know about how many people will be vaccinated and how effective the vaccine is. So if you want to model and say, over the next 5 years, this is how many flu cases we expect to have. This is how many people, this is a range of, the number of people that will die. because we have solid information telling us the assumptions to put into the model. And so that's how models are built. They're built on historical information that creates a best guess about what could happen. So think about that in the context of this pandemic. Mm-hmm. What do we know? We think we know what was happening in China, but even something like the total number of cases, that information can never be known. Mm. How frequently the cases were doubling or tripling or increasing exponentially, that varied from country to country. It would be different. It was going to be different when it got to the US. And so the challenge with relying on models to guess what would happen, I think, is a recipe for creating misinformation, or what's perceived as misinformation, particularly from our leaders, our public health leaders, political leaders, is because people can take that information and they can manipulate it to say whatever they want that suits them. Yeah. So and I know it frustrates the public. I get a lot of questions. Well, what do you mean? How did they change from 1 million deaths to 60,000 deaths? And that's the reason. Because
or even
it's unclear.
Yeah. Or should we be social distancing or not? Like, mm-hmm. I mean, I think that politics plays in, and, the concern for the economy is real. But, there's so many messengers that are out there. And so both of you have really expressed the commitment of getting information out there and making sure that public health options get to the people that are on the street that don't understand and have the backgrounds that you have, so that we can take care of ourselves. And so do you have recommendations for people listening on where, if they were going to go to a website, like what websites should they go to?
Oh, man. I'll be curious to see what Natalie has to say about this. I think it's hard for people. And this is why I've waded into this area. Because I see myself as a trusted, credible messenger, simply because I have the background to look at science. I understand medicine. I understand people. And I'm not afraid to say I don't know something or try to find the answer if it isn't there. And so the challenge with a lot of what we're hearing is that we don't know what the sources are, or if the information has really been vetted. And I often refer people to CDC website for general information, but CDC only will give general information. I mean, as someone who worked at CDC, I understand how CDC operates. It's an agency that provides guidelines, general information, information about disease trends. It provides a lot of general public health information, but the kinds of things people want to know about how to shift their lives or their patterns or their ways to behave, I don't think you can get granular information like that from something like a CDC website. And I also think people, they do the best they can. And the other reason my company is called Grapevine Health is because when we ask people where you get information you trust, they said they talked to their mom or their grandfather or their friends and family to get information. And I think this is what's happening. And now we have so many experts all of a sudden. Everybody's an expert on coronavirus and pandemics. And if you say something with enough authority, like I've seen in some of these videos on YouTube, why wouldn't someone believe you?
Yeah. I was also going to recommend CDC. It's interesting, as we've talked to some people, and this has not been scientific, but as we talk to people, across the country and ask them, like, where are you getting your news? What are you finding? What are you turning towards to get the information you need? It's been really interesting, and it resonates with me. A lot of people are like, I just can't anymore. It's just too much. It's too scary. Yep. I don't know who to trust. A lot of people do trust Dr. Fauci when he's up there with the president and CDC. But it's just been really interesting to hear. There's been a lot of people that have just said, I can't read anymore, or I have to do 10 minutes a day. or I just talk to my family about it because it's anxiety inducing.
Mm-hmm.
I would add, though, I think part of the challenge with listening to data, the projections about modeling, is that it sets people up for distrust. And, this notion that we have revised the death estimate so drastically will lead people to say, well, why should we believe anything you say? There's a lot of daylight between 60,000 cases and 1 million cases. And I remember Dr. Fauci saying early on that when this is all over, people, if things go as they should and we mitigate spread and reduce deaths, people will say you overreacted. Mm-hmm. But that's the cost of it. That's the cost of reducing the impact, because you'll never see what could have happened. But I think the distrust around the messaging is definitely linked to all the unknowns about how we're coming up with this information and just asking people to believe.
Yeah. Is there a scenario in which the United States could have been better prepared? So I don't understand, I'm not a scientist. I see, I'm like, this just, this happened, it showed up, I don't know how pandemics work. Is this something where we were hit and now we're bringing experts in, or is there a scenario in which we could have been better prepared?
Oh, yes.
Say more.
I will. Let's talk about outbreak 101. When there's an outbreak, let's say it's alfalfa sprouts that are contaminated with E. coli. The health department starts hearing about these unique cases, and then they send people into the community. These EIS officers usually are people from the health department, and they figure out the source. And once they find the source, then they find all the people who could have potentially been impacted by that. And they look at those people and the people connected to them. Or maybe a better example is when you find cases of tuberculosis or some other kind of respiratory infection that's transmissible. You first have to find the people who have it, the cases, and then you isolate them or you put them in quarantine, and then you find out who they've been around, where they've been, and then you find those people, if there are any infections, and you quarantine those people, and then so on until you mitigate spread and you stop the spread because you found all the cases. So we didn't do that, and that's basic public health, basic outbreak strategy 101. So when the first case, and my understanding is the first case in the United States was a business traveler, actually he had been in China, but he was in Washington State. And when we knew about that case, we should have been aggressively conducting contact tracing or looking for his patterns. Where had he been, in the previous weeks before coming to the United States? Where had he been? Where did he go after he got off the plane? I mean, all the people on the plane should have been contacted and tested. And then all of the places he went after that. Who did he come in contact with to find the cases? And that's how we could have stopped the spread. So think about all the where are the planes coming from? They're coming to different places. New York. So we see what's happening in New York. I think the mitigation or the public health efforts in New York were far too late. And that's why we're seeing the spread. So yes, there could have been a much faster, a much better response. We all know that we didn't have enough testing in the beginning for a variety of reasons. But these are huge mistakes that are costing us now.
Mm-hmm. And speaking of testing, I mean, I have been listening, to folks in New York talking about this bidding war for ventilators and masks. And, I have been personally floored. And I think I'm one of those people, Natalie, that are like, I can't watch anymore because just thinking about the United States not having enough equipment to just do testing is paralyzing for me, much less taking care of people once they get to a state that they need more urgent care. Is that because it was politicized, or is it because, probably a combination of the the lack of preparation?
I think this is a story that will be told years from now, and I think there's a lot more information we don't know about, but we do know that CDC. So let me back up. When China first published the gene sequence for this virus and told everybody, they did it in record time. I think it was in 11 days or something like that. They were able to isolate the virus, look at the whole gene sequence, and then they published it so everybody in the world knew what it was and they could make their own if they wanted to. CDC chose to make our own, and then it didn't work. And I think we lost time there. But and that's that's human error that happens. But I think the misstep was not having a plan B and sourcing tests from wherever we could, even if it meant outside the United States, even if it meant securing the support of the biotech industry. We have a very robust and healthy biotech industry in the United States. And so there were challenges, bureaucratic challenges at the FDA and so on. And so these are the things that contributed to our inability to roll out testing on the scale we needed to find cases early and begin that public health response I was talking about earlier.
And if we were to look forward, are we in a better scenario now? Okay, there were human errors back then, but are we in a stronger place now to address this from your
I don't think so. I think we're definitely in reactionary mode, and we generally are. My understanding is there were simulation exercises around this exact scenario that happened, and we still were caught flat-footed. So no, I don't think we're in a better position now. However, I will say every state will not be like New York City. And that's an opportunity. That's an opportunity to implement the basic public health outbreak strategy I was talking about. So if it's, a state, particularly these states that haven't locked down, there's a public health opportunity for them to find the cases aggressively. And if they refuse to lock down and refuse to implement social distancing, at the very least, find test kits somewhere, source them, and find the cases and do the contact tracing so that they don't have an escalation in cases. And I think all states really should be doing that now.
Mm-hmm. And how do you address the states that haven't locked down in terms of travel, like domestic travel?
Yeah, it's a little. So this is interesting to me because I think what's happening, it's all about the optics. And if they're not seeing a lot of spread in their communities, they're thinking, well, this isn't really affecting us. Why should we take the risk of destroying our economy when nothing is happening? And I understand that. But again, if that attitude is not accompanied by an aggressive, overly aggressive public health effort to find cases and ensure what they believe is true, because it's not enough to say, we don't think we have cases. You have to know for sure you don't have cases. But then there also needs to be some sort of travel restriction or border control or something to mitigate the spread and the transmission of virus.
Natalie, can we maybe step back a little bit from COVID for a second? It's related, but how does politics play into healthcare?
We at United States of Care have thought about every 10 years, the nation takes a stab at federal national level reform of our healthcare system. So and this has been for decades, this has happened. And so if you think about in the most immediate decade with the Affordable Care Act, it became something that you hung your hat on whether you were for it or against it. And while it wasn't the first time that healthcare has been politicized, it's the most recent time that it has been intensely simplified and brought to a level of if you're either for it or against it, and you'll vote on your party line. When we've talked to individuals, this idea that their health and the health of their families is a political football, and that there's no positive vision, no way to look forward to what could be in a future kind of reform effort that would actually be based on their needs. It's almost like a foreign concept, this idea that healthcare may not be political. And so I think there's going to be a time where, and this epidemic might be the moment when I'm not going to say that healthcare won't be political anymore, because we're already starting to see the response to COVID-19 politicized. But this may be a time where we realize the health of our neighbor and the insurance status, and if they're able to get the care they need, matters for your own health. I know Lisa and I have talked about this, and she thinks that I'm too optimistic, that it's not going to change a lot. But, I do think there's a moment for us to talk about as a country, what does it mean for our frontline healthcare workers and nurses to be well equipped? And what does it mean for your neighbor to literally put their lives on the line by working in a grocery store? And what if they don't have insurance? We now have 10 million plus people uninsured because they lost their job, or possibly uninsured because our country ties insurance to employment. And so it's raising, I think, a lot of questions. We have the opportunity to raise a lot of questions about what we want our country to do in terms of access to insurance, access to care. The idea that there are people that don't want to seek treatment right now because they're an undocumented immigrant, or they are worried about if insurance will cover the care they would need if they got COVID-19. I mean, these are questions that people shouldn't have to ask themselves, but are. And so I do think it's a moment to step back and say, what do we want our healthcare system to be?
Yeah. And if we were
Lisa has differing.
Yeah, I want to hear from Dr. Lisa's differing opinion. But Natalie, if we were to actualize your optimistic vision of really seizing the moment, are there things that people, like, what would that require, especially from the everyday person, and what would need to happen in order to fulfill that vision?
I think a lot of it is the work that both of you do. We need to go into community and talk about what's working and what isn't, and not presuppose we have a policy idea that we just need people to support, but understand what's working and what isn't, and use that as a way to build a better vision for healthcare. I mean, look, we have been talking about virtual care and telehealth for a long time, and it was never a possibility. And the nation, and including the education system, flipped in 2 weeks to be able to give people virtual care, which is amazing. We need to understand if that's going to increase disparities or increase access to care. I was speaking to a nurse in rural Wisconsin who shared with me when she was able to start working from home, her broadband is so poor that they had to decide her kids couldn't do at-home schooling because they could only have one laptop on the internet. And so they chose her job because they needed the income, of course. So while we are able to switch to telehealth, we need to understand, where is that working? Where is it not? How is it going to increase access to care, and where is it going to worsen inequalities? But we need to do that by understanding what works for people and what doesn't, and not presupposing that we know the answer.
And Dr. Lisa, your vision is less optimistic, but what do you think will come from this?
So I always like to say, where you stand is where you sit. So I share some of Natalie's optimism around the changes that will happen as a result of this in the way we deliver care. I've been a digital health and telemedicine supporter for a long time, and have actually wanted to stand up a digital health resource for Medicaid patients. And I still think that's very necessary. I think the disparity, we will see the disparity. I actually am planning to write about this. I'm a Forbes Health contributor. And so one of my next blogs will be about where are all the people who are not going to the emergency room right now, and are they using telehealth? So I interviewed someone from one of our federally qualified health centers, and she said a lot of people have phones, but the challenges with bandwidth, data access, it makes it challenging for them to do video visits. They're able to talk on the phone fine. But it just, again, reminded me about, even though we probably will make this shift permanent with telemedicine, but we have a lot of work to do to make sure that everybody can equally access it. So much so that, if you know any telecommunications providers, maybe we could get some sort of, mass donation to allow people to have access to service and smartphones, those who don't have it during this crisis. Because if they're not going in, before this happened, our emergency rooms were flooded with people in heart failure, people who had missed dialysis and needed to be seen, or who had an asthma exacerbation. Where are they going now? So we need to provide some support for them. But the reason, and Natalie's joking a little bit about my skepticism, but I think the biggest reason I'm skeptical about the future and how much this will influence what happens is that I think we, as a nation, have very short memories. So I think at this time, in certain pockets, there's some solidarity, but in other, people are saying we're all in this together. But what about that homeless person I was talking about? Or what about the family that can't socially practice social distancing when they live in a house with 4 or 5 people and one person has to go out to work in a supermarket or drive a truck every day? We're already forgetting about those people. And once this passes, I think we will still be staring at these health disparities that we've been talking about for decades. And so I don't think this will be our pivotal moment to address those things, because we've had moments like this before. Katrina comes to mind. I mean, it was a glaring disparity the whole world saw. And now here we are again. So I don't know. I want to be optimistic that this will incite new conversations, but I'm not sure it will. I think the right people have to be at the table. And I'm so glad I'm on this call with Natalie, because US of Care can be so influential in making sure the right people are at the table when we're having conversations about how to address these long-standing, intractable health disparities.
Mm-hmm. And I imagine that, I kind of share your concern, right, of folks that aren't going to the doctor. So you have the data that came out on who's being fatally impacted by COVID-19. There's information that is very consistent with the health disparities that we knew were happening. Those folks that are out on the front lines now, those folks that had underlying health issues. The Black community is being gravely impacted in this moment. And I can't imagine right now, like, for folks that really didn't understand disparities, here's a moment for them to really understand how those disparities play out. Even talking about school and education, Natalie, you're homeschooling your kids right now. I'm homeschooling my kids. And I've been in conversations with people that don't have pencils and paper at home, right? They don't have a table to write on. And we're talking about broadband, and they don't have some of the basic essential sort of furnishings and tools for education, like paper and pen, because they didn't have it. That's not where they're spending their resources. And I think it will exacerbate in many ways the disparities that we see. I hope in our work in philanthropy that it feels like there's a perfect place for philanthropy to be around both supporting Dr. Lisa, maybe it is the messaging that goes out. It's, the platform. I hear broadband. I mean, I hear a number of things in my listening to you both on things that we can do. Are there other things that you think specifically for philanthropy, because that's where I'm sitting right now, that, in ways that we can help? Because I would hate to see the country go backwards or to deepen the disparities that are already so deep.
Well, I think I've been deeply interested in philanthropy for a long time because I'm fascinated by how difficult it is to get money from places for things that seem so obvious. And having started a nonprofit in the past, I don't understand why it's so difficult when we talk about the need to address health disparities. And now where everybody's talking, before COVID, we were talking about social determinants of health. How do we provide the services and the supports that people need in the way they need them? But the money is not flowing to match the need. It's so interesting to me. The funders seem to be much more interested in metrics and measurement and ensuring that the organizations are equipped to do what they say they'll do in their applications. But the challenge is that I have so many thoughts about this, but I think the challenge is that the foundations particularly need to be more flexible at a time like this and more nimble to meet the needs that are in front of them. And I'm not just talking about giving money to food banks, but some of the things we're talking about. How can we mobilize resources so that people can educate their kids at home, or they can access a smartphone so that they can have a video visit with a doctor? Or what about remote monitoring? So someone with congestive heart failure, for instance, maybe they need access to a pulse oximeter or some way to measure whether or not they're putting on weight because they have fluid retention. There are so many technologies out there that could help support this sort of, clinical, the diagnostic needs for these patients. But to try and get money for things like that from foundations in an urgent situation, I think would be really challenging because it's not how they're structured. The bureaucracy prevents them from helping people in the way they need to. And the last thing I'll say is I've tried to get money from a lot of these organizations to address the misinformation or to focus on health literacy. And because it doesn't seem like a sexy research project, or it doesn't have sort of the policy implications or something they could actually use to move a policy around health reform or SNAP benefits or something like that, then it's not seen as something in their wheelhouse. And so I've turned my attention to things like raising money from friends and family. I launched a GoFundMe campaign because I got tired of trying to get money at this critical time to address misinformation. I got tired. And so I'm having some success there, but I just think that my message to funders is put your money where your mouth is. If you say you want to help people, you have to listen to what the real needs are and put some of your requirements and some of your notions aside about how the money should be spent and let the money flow to help people on the ground.
Mm-hmm. Yeah, and I echo what Dr. Lisa's saying. And, this is a moment for foundations and philanthropists to stand up and practice altruism and strengthen communities where we all pivoted and quickly, we turned the United States of Care to focus completely on COVID for the time being. And Dr. Lisa is talking about what can she do in the immediate moment to help, her community and other communities really get through this really extremely trying time we never have. And, that doesn't always mean a perfect work plan and a perfect budget, but it does mean that there are a lot of things that need to happen now. and need to continue to happen to continue to build a healthcare system, an education system that meets people where they are. Earlier we were talking about having the right people at the table. Well, if being at the table means you can't be at the table because you can't take off work, or you can't have someone watch your kids so you can come, be at the table. We're really interested in United States of Care is how can we let people afford to be at the table? How can we, but that's not traditionally funded. How can we, make sure that communities are able to gather and talk about what's working and not, but that means we need to be able to resource that, to understand, like Lisa said, what's going on and how to use that to inform the work to do. And so philanthropists and foundations, I think, have a big role that they should be filling right now, which is getting money out urgently and jumping off the ledge like all of us are and trying to do the right thing. So,
yeah, I think
the risk tolerance is not high enough, because I find a lot of funders will turn to known entities or known organizations who've always had the infrastructure and the capacity to get money, to write grants, to say the right things, to create the work plans, as Natalie was saying. But they don't necessarily have the emotional intelligence or the connection to the people who need the support, or even to the community to invite their voice into the process. That's who needs to be funded right now.
Mm-hmm. So I hear a couple of things that I want to point out and just make sure that I'm hearing it in the right way or putting it out, because I do think that philanthropy, at least in Minnesota, is responding and getting more money out the door and being more nimble in process. What I can say is that those dollars are going a lot to the basic needs, the food, the worker, the gig workers, the healthcare, and that from one point of view, we are being flexible in that what used to take 6 months is taking 1 week, right?
Wow,
like
wonderful.
An application, we've gotten over $1 million out the door within 3 weeks, like 270 proposals we've read, right? That's incredible. But to your point, that they've gone to organizations that we have been familiar with for the most part. Folks that are comfortable enough, at least, to fill out this very low barrier, right? I'll speak for just the Minneapolis Foundation. But what I also hear around the nimbleness that I want to make sure that I point out, and that I heard it correctly and have you reinforce it if I heard it right, is that a piece of nimbleness also means being open to ideas that you haven't heard, and to fund people that maybe you haven't been in relationship with in the past. Because it's one thing to be nimble within the known. It's something else to be nimble within the unknown. And that in a situation like this, it actually will require innovations and new approaches, that we have to be nimble enough, not just in our process, but nimble enough in our thinking, nimble enough in our expectations, nimble enough in our sort of our risk sort of scenarios, to be able to allow some new strategies to come into play.
The Minneapolis Foundation is a leader as far as foundations and getting money out and putting it in the community. And it's why it was so great to be on this today. And I'm genuinely asking this. Do you know if that has been similar in other states and other foundations across the country?
I know that it's really consistent here, even with my counterparts. I have talked to some of my colleagues in other states where I don't think that is the case. I do think that there are some places that are gathering the large foundations in their states. And what I would say is that they're creating kind of an alternate sort of bureaucracy that is slowing it down. And even with the slowdown, I think they're being quicker than usual. So, I'm not an expert there. But I can say that here in our state, it's been really wonderful to see. But I do think that innovation does matter. And I came from the other side of the work, right? I ran a nonprofit. You mentioned a food desert earlier. When I was leading, I worked really hard with my partner, who's now CEO, Adair Mosley, at Pillsbury United Communities, to open up North Market, which was in the middle of either a food swamp or a food desert, whatever you want to call it. But I will often say that if we would have wrote the proposal to open up that grocery store, it wouldn't be open now, right? Like I'm like, my best ideas probably went into like the virtual trash can, and that I had to really prove a lot to move those things. And those early investors where our corporate partners and certainly philanthropy came in. So, I don't want to discount that, but the support from the onset matters a lot. And so I'm both trying to say, me personally understand kind of the angst of what you're describing, Dr. Lisa. And, as we close, I think you gave, number one, I think what you're talking about is both flexibility and process, but also being flexible to letting new people in with new ideas that perhaps you don't know of, right? So if you're moving your own theory of change with very limited understanding of either an issue or limited connection to community, you're not in the right position to have the impact that you could have if you invited people in that had both the expertise and the relationship.
Very well said. Amen.
Amen. Thank you both. Is there anything that you want to say that I didn't ask or we didn't cover?
I just want to say you have some kind of Black girl magic.
Thank you. Thank you. You got it too. I can feel it through here. I saw your picture today. I'm like, look at those dimples. I want to talk to her. all those brains, all that talent, and, that passion for community. I am just, I'm trying to use this platform that I have while I have it to really challenge philanthropy, right? To challenge the Minneapolis Foundation, to say, we are collectively very smart, but people on the ground are smarter than us. And even with the grocery store that I was instrumental in, it was right down the street from where I live now in North Minneapolis, which is historically a Black neighborhood. And in my listening sessions, I heard things that I wouldn't have thought I would have heard, right? Where I'm like, what do you want to see? What type of classes do you want to have in the store? And people are like, we want composting classes. And I'm like, composting classes? Like, I would have never thought that on my own. And so I often say to people, like, I'm 5th generation in this neighborhood. And when I ask people questions, I learn something new. Like, I depend on those voices to inform me. And if I'm this close, I'm this proximate, I live in the same zip code that we're trying to address, and I still feel like my orientation has to be to connection and listening, then I don't understand how you can't have that orientation. Right. And so I appreciate you being part of my own personal sort of kind of passion of bringing in voices and connecting it to policy, to action, to improvement. So I appreciate it. I hope we stay in touch. If you need anything, Dr. Lisa, I'm going to be looking at all my dollars to see if we have any campaign dollars for you.
Well, I want to take Dr. Lisa on the street, on the road to different cities, especially now, to talk to people and see what's on their mind about, this pandemic and lessons we've learned. So maybe I should include a stop in Minnesota.
Yeah, sure.
Please come to Minnesota. And, I was sharing with Natalie, I have a son, the car dealership he works for is still open.
Essential service.
I'm going to interview.
Yeah, you can talk with him. I have other folks that are around me that are still working. And especially, I think, in that 20-something population, because that's I'm watching them with their card parties and everything else on Instagram and stuff. And I'm like, young people, come on. So, but both of you, if there's a way that I can be helpful, please let me know. And if I have questions, I'll reach out to you. And for sure, stop here, Dr. Lisa, for sure.
Yeah. And thank you so much for your leadership in all of this. It's you're a legend that I've heard a lot about. So I really appreciate you bringing us together and all of your leadership. So thank you.
Thank you.
Thank you. I really appreciate the invitation to be here. And I look forward to connecting with you.
Sounds good. Thank God it's Friday, and enjoy your weekend.
To listen to more episodes and learn about upcoming events, please visit conversationswithchanda.org. You can follow Chanda on Twitter @Chanda S. Baker This is Sue Pak Kienitz from the Minneapolis Foundation. Thank you for listening to Conversations with Chanda.